This talk is something that I give to physicians, to medical professionals often. And I thought about changing it up just because of the audience, but then I stepped back and then said, no, like I think this is important for you all as well. And part of it is because, as we talked about in the first aspect of things, is that in one, this is helpful for you in your day-to-day work life, but this is also helpful for you in your life as a patient or your life as a family member that's a patient. So I think it's important to have this sort of a talk directed to you as well. So there's my disclosures, my objectives. I have a lot of them. But I think the biggest thing is like when we're working around with talking to people is do we need to do better pain control? And the answer is yes. And we as physicians have said for years, we're doing a great job. The 1990s, they're like, we're going to attack pain, and pain's the fifth vital sign, and let's do everything we can. And you look at surveys from the 90s, the 2000s, the 2010s, pain is the same. 80 to 85% of patients having surgery say they have moderate to severe pain. And when patients were treated with pain in the hospital, all we did was throw opioids at them. And what do you need? You're in pain, here's more opioids. You're in pain, here's more opioids. You're in pain, here's a different opioid. So we didn't really think of, well, what's going on with this patient? We didn't have conversation with patients about what's going on. Patients coming into surgery, pain is still the #1 concern. Right now, oncology patients may be a little bit different, but for more in general of surgery, patients worry about how much pain am I going to have? And Americans, we're different than every other country in the world for whatever reason. We expect to have surgery and not have pain afterwards. And that's a huge issue with Americans. They come into surgery, they're like, I don't want any pain. I'm like, you're getting cut open. You're going to have pain. There's nothing we could do about it. But we just think, like, we don't want to have pain and we want to have this surgery. So getting them to really change their expectations is a big thing. Patients still get opioids. We have patients, and we're finally starting to change this. But I've had patients for years say, yeah, I went to surgery, I told my surgeon, I don't want that prescription. They go, fill the prescription. I don't want the prescription. You have to fill it, because they don't want that patient to have pain on Saturday, and now they need an opioid. Well, now they have to call the surgeon. Now the surgeon has to drive into the hospital. Now they have to sign a prescription and hand that over to the patient. Well, that's an inconvenience to the physician, and I totally get that portion of things, because I'm anesthesia, I don't have to worry about that. But if I was a surgeon, yeah, that's a big inconvenience to myself or my partners that have to do that. Because, right, we want to attack opiate prescription misuse, so it has to be handwritten. Right, that's starting to change, but those are some of the issues that why physicians for so many years really push those things. Non-opiates are prescribed PRN. I'm finally getting my surgeons to change this. They'll say, here's your prescription for oxycodone, take Tylenol and ibuprofen as well. When that patient's in pain, they forget about Tylenol and ibuprofen, and they just take oxys. If they write a prescription for Tylenol, ibuprofen, oxycodone, you give that to the patient. Patients, when they get a prescription, typically are pretty good at following directions. It says I have to take this medication now, I'm going to take that medication. It says I have to take this medication now, I'm going to take that medication. But if you say just take this, but here's your prescription, they're going to end up just taking the oxy. And if you don't have a constant blood flow of Tylenol and ibuprofen in your body, you're going to take more oxys in the postoperative period. And HCAPs, right, a lot of physicians have various views on HCAPs, but HCAPs was not good for pain. They incentivized hospitals for pain control. The government thought this is a great idea. Hospitals will do a better job with pain control. Nope, hospitals and physicians are always really good at finding ways around things to keep their money. So what they did is give everyone as much pain control as they wanted. If they wanted more opioids, they said give it to everyone, because then they'll say we gave them good pain control. If we didn't give them opioids, then they would say they were the worst pain control ever, our HCAP scores were down, now we're going to get penalized from the government. So it really was a good thought, but really ended up really contributing to this factor. We know that pain control is important. It has a huge impact on hospital length of stay, readmissions, patients' quality of life, return to work, return to function, all those things that we want to avoid. And so we really need to do a better job at controlling this, because it has a big impact on patients in a lot of different aspects of their life, as well as us, right? If patients are in pain, if I'm on call, I'm getting called in the middle of the night, or they're going into the emergency room, or they're staying in the hospital longer. All those things that we want to avoid as well. So it impacts physicians, hospital administrators, payers, but most importantly, patients. Risk factors, strangely females, which I still can't believe, because the wimpiest patients in the hospital are people 20 to 30 years old that are a man. They are the wimps of the hospital, but females, for whatever reason, these studies rank higher. But if younger patients, for sure, a 20-year-old patient coming in covered in tattoos, you know they're going to have a ton of pain. A 90-year-old patient coming in and having surgery, you could chop their leg off and they're like, it's a 1 out of 10. I've been through worse. 20-year-old patient has like a finger cut and they're like, it's a 10 out of 10. This is the worst pain in the world. And a lot of it's life experience. A lot of it's how you perceive pain and all those types of things. Your catastrophizing score as well. BMI, larger BMI patients on opioids coming in, and that's more and more common. A big thing with providers now is how do you manage all these patients coming in on massive doses of opiates, or now, how do you manage these patients coming in on Suboxone and all these other medications to try to avoid them, or methadone, to try to avoid their addiction issues, and how do you manage them? It's not easy. It's really difficult to manage those patients. Patients are worried about this. 30% are worried about becoming addicted. A large portion of patients prefer non-opiates. But we don't talk to our patients. We just say, you're having a total knee replacement, you're getting 60 pills. They don't have the conversation of, well, what works for you, what doesn't work for you? Do you want to try to minimize opiates? Do you want an opiate-free pathway? We can give you that. And trying to really get hospitals to really start having opiate-free pathways for surgery so patients can have that option. Because there are patients that would come in and say, yes, let's try that option. We've done it with our C-section patients, and we're starting to do it in other areas to really develop this pathway to say, here's a choice. And patients like having a choice in healthcare. So much of it is coming in and you're doing this and you're doing this and you're just funneled through things. But if you have a choice in your say, patients tend to be more satisfied than if they're just told, do this, do this, do this, do this. Right? We know how many patients get opioids. American uses 80 to 85% of the opiates in the entire world. Think of all the other countries in the world and what our population is compared to the world population. We use almost all of them. So I don't buy the fact that, well, you need opiates for this surgery. No, you don't. I can send you to India and you can get a total knee replacement and you'll get Tylenol and NSAIDs. You're not going to get opiates in these countries. And yet the patients still do fine, they're still alive, they still have good outcomes, and they're still satisfied. A big part of it's our expectations that this is what I need when I have surgery. They have a bunch of negative effects for patients. You talk to patients as well, like my mom is a big one. You give her opiates, she's going to puke her guts out. So she's having surgery, I had to call the anesthesiologist, talk to them, say, okay, here's a technique. Don't give her opiates in surgery. Try this, 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 this. That will help her. If she needs it in the PACU, then give it to her. But don't just front load her, because then she's just going to puke in the recovery room. So, but we just follow these protocols and don't think, what does this patient want or what works better for this patient? Because they have a lot of side effects. And Jayco has said, this is a sentinel event. We got to be aware of opiates. And then it's like elderly, sleep apnea patients, chronic pain, and obese. Well, that's the majority of the patients I see every day in the OR. Most are elderly, most are obese because we're in America. A lot of patients have sleep apnea. So these are all things that we see every day. So this sentinel event is a big thing that we need to be paying attention to in the hospital. Opioid-related deaths, as we kind of led off with, they're skyrocketing. And you can see the change in how patients have died over the years. And in the last 5-6 years, how much more. And part of this has been our reaction to the opioid crisis. Right? America does a wonderful job of swinging the pendulum side to side instead of keeping it in the middle. So in the 90s, 2000s, we swung to the left. Everyone gets opiates. Opiates aren't addictive. Surgeon General is on tape saying opiates aren't addictive in the 90s. Now in the 2010s, oh no, we're in a crisis. Swing the pendulum to the right. Nobody gets opiates. We can't give opiates. Opiates are bad. What are all those patients addicted to opiates going to do? Find the next best thing. Well, what's there? Heroin. So they can get, if you want to buy a Percocet on the street, what's it cost? $30 in certain areas. Not that I know, but but it's $30 for that. How much is a hit of heroin? $6, $7? So eventually, whether you can't afford opiates anymore if you're addicted, or you can't get them because the emergency rooms aren't giving them out and your doctors aren't giving them out to you. Well, we didn't put any programs in place to help these people. We just said, our hands are washed, but you're not getting any opiates. Well, now they're on heroin, and there's a smaller window of safety with that. Well, As heroin goes down, right, they can't get heroin, or they're like, heroin has a stigma to it. What do they do next? Fentanyl. Fentanyl is a very potent medication, and the most deaths that are occurring now are patients on fentanyl or carfentanil or some variation of that. And there's a slide a little bit later where it shows the skyrocketing of deaths from those medications. And it's because you could be on that medication, and if you're on oxycodone, you're taking this level, you go off it for 1, 2, 3 weeks, you can usually go back on that same level without any deleterious effects. If you're on fentanyl and you go off it and go back on that same dose, and a week later, that could be enough to kill you. And that's probably, I didn't take care of him, but that's probably what contributed to Prince, right? He was on it, overdosed, probably went off of it for a week later was dead. Probably went back on the same dose. And so that happens very commonly with patients or people that are addicted to this, and we need to do a better job of combating that with our patients. Drug overdose deaths, 64,000 is probably higher than that. It's more than the peak car crash deaths in the entire US, that was in the 70s, more than the peak HIV deaths, which was in 95. So the amount of deaths every year from drugs is more than the HIV epidemic, which everyone was aware of, more than the most motor vehicle accidents, more than the total amount of Americans that died in the Vietnam War. So this is a huge thing that we really need to have people really looking towards in terms of assessing this crisis. Deaths, as we can see, is continuing to go up with prescription drugs. Deaths from heroin is skyrocketing, as I talked about earlier. And so giving this talk in Minnesota, it's very easy to say, well, we're Minnesota nice, we don't have this issue here. That's Florida, that's California, that's New York. It's not the case. There's more Minnesotans dying from opiate deaths than motor vehicle crashes, and that finally flipped in 2016. And think of all and not even just motor vehicle crashes, but think of all the focus on drunk driving, all those types of things. But do we do that same focus with opiates? No, because it's a different thing, it's a stigma attached to it, and we don't really think about it as that. You can see the different drug types in Minnesota. You can see this kind of steep curve with fentanyl in the last few years. And this is the scenario. So if we do nothing, this is what's going to happen. And then there's different things that the CDC went through. Is if we do this to combat this, this is the impact it's going to have. Top drugs prescribed in Minnesota: hydrocodone, oxycodone, or Vicodin, oxycodone, Percocets, and amphetamines. So the top 4 are all addictive medications that patients get in Minnesota, the top 4 prescribing medications. Just University of Minnesota Fairview System-owned, the system that I work for, we prescribed 24 million pills 2 years ago. And that's one of, 12, 13, 14 hospital systems in the state of Minnesota of only 5 million people. And we're putting 24 million pills out there. So if our patients aren't getting addicted, their relatives or their kids or their grandkids or their neighbors are coming over, right? You get a bottle of pills, it's 50 pills, you take 4 and put them in your medicine cabinet. You almost never go back to your medicine cabinet and say, oh yeah, there's 46 pills there, let me check if there's still 46 pills there a month later. It just sits in there and someone comes over, goes through your stuff, and steals it. Up until a few years ago, in the state of Minnesota, it was illegal to have pill return boxes in pharmacies. The only place you could return your opiates was the police station or the fire department. And you couldn't bring it to the hospital, you couldn't bring it to your doctor. Think of our patient population, or just think of, in general, how many people feel comfortable walking into the police station with a bag full of narcotics and say, here you go, please dispose of this. That was never going to happen. So we finally got them to change the law so that they could put pill return boxes in a CVS or a Walgreens, and you can see them everywhere now. And they're bolted to the ground, and they're foolproof. And the argument was, I was like, oh, we're going to have all these people coming in with guns and holding up the pharmacy and trying to take all these drugs. I'm like, I highly doubt that's going to happen. And it doesn't happen. And it's really improved the return rate for people to dispose of this. But you have to have that conversation with the patients. If you have leftover pills, don't just leave them at home just in case. Bring them back in, dispose of them in the pharmacy, and get rid of the extra pills. Because while you may not have an issue, your family members or your neighbors or your kids may be in trouble with this. So why does this matter, right? Patients can go onto opiate use. 1 in 15 patients that come in for surgery, and we do 60, 70, 100 surgeries a day, will have some sort of chronic use with opiates. 18% of opiate-naive patients were still on opiates a year after spine surgery. 6% after all orthopedic surgeries were still on opiates after 150 days. So they get on it and they just never go off of it because they keep having aches and pains and they just keep writing the scripts because it's easier to just write a script, go on to my next patient because I have to see 40 patients in a day or I'm not going to be meeting my RVUs and I'm not going to be able to get my bonuses or get my, I'll keep the administrator off my back. It's not just young people, right? It's not just the 20-year-old kids that are experimenting with drugs. Elderly patients have a big issue with this. Patients over the age of 65 are still on it, 10.3% a year later after surgery. 44% likelihood to be a long-term user if they were over the age of 65. Young patients as well, adolescents, teens. If you're an athlete, you're at greatly increased risk of having opiate misuse issues in the future than if you're a non-athlete. And part of that's because they get exposed to opioids earlier. So for most people in America, now we're finally changing this, but in the past, your first exposure to opiates was typically third molars or wisdom teeth. You have wisdom teeth, they'd write you a script, and that's when you got exposed. But athletes a lot of times would have some sort of an injury, and you'd get it a lot earlier, 12, 13, 14 years of age. Your developing brain, getting these medications, getting those in, that had a long-term effect on those patients, whether or not they were going to use or misuse in the future. We talked about elderly deaths, so this is a Minnesota thing as well. 47 deaths in 2013 in the elderly. And I kind of hit on this earlier. If you get pills, most patients don't take all their pills. So in the last few years, we've really did a lot of reform on prescription writing. And so stop writing these giant prescriptions so you don't have to be bothered because that was an issue. We had surgeons that would write, so there was a change in now residents can't write opiates because we don't trust residents, and so they can't write an opiate prescription. So then the surgeons, on the day of surgery, would just write 150 pills, leave it in the chart so that when they got discharged, they didn't have to wait for the surgeon to get out of the OR to write the script or their partner to do it. So they do it the day of surgery. It didn't matter if that patient on day 3, when they were ready to go home, took 0 opiates the day before, they still got a script full of 150 pills. And so really changing that to really say, how do we direct this to our patients? And there was good study in the last year that looked at how many pills you were taking the 24 hours before discharge after surgery. So if you took 0 pills in 24 hours before discharge, you could discharge them without opiates. If you took 1 to 3, you could discharge them with a script of 15. If you took 3 or more, you could discharge them with a script of 30. So adjusting based off of the patients and not just, this is what we do for every single type of surgery. And this is just various things. Most patients have them, unused pills after surgery. They kept them in an unlocked cabinet or a medicine cabinet, and very few had a plan to discharge them. You talk to patients, what do you do with your unused opiates? I don't know. Some say flush down the toilet, throw in the garbage, bring back into your office, or just leave them in there just in case I fall and I hurt my back, and then I could take a couple of Vicodin at home, and then I won't be in pain. That's not the right way to adjust it. So really educating patients on this as well. And right, the emergency room colleagues here, I guarantee they've heard this story because I heard it in the 2 months I did as an intern when I was working in the ER, is patients come in, they have an injury. Well, what happened? Well, I took some pills from my husband's leftover pills from their surgery. I just had a couple of Vicodin from him, and I'm feeling a little bit better, and this was going on. That happens very commonly, and it's not what we want patients to be doing. Everyone's kind of aligning on this, and right, some of this stuff is, when I first started talking about this in 2012, nobody really cared. My hospital was annoyed by me because I'm like, we need to do this, we need to make these changes, and they say, opiates are cheap, they're fine, let's save money somewhere else. You're just going to spend money for this. But they didn't really get behind this. But you start to see a lot more recommendations. The HHS just came out with some wonderful guidelines like May 30th of this year, which really goes into acute and post-op and chronic prescribing effects. So what do we have? What options do we have? Well, multimodal analgesia is those options. Let me just make sure I'm not way behind. All right, 10 minutes, perfect. So multimodal. So this is where I left this part in here. I was like, well, do you really need to know about all these options? But I think it's important because when patients are advocates for themselves, that's probably the best way to make physicians change. We don't like change. It's hard. We spend enough time just trying to figure out the EMR. I was telling a story earlier. I remember when the EMR came out and they had signs that say left button, right click button, and the surgeon's like picking up this mouse and like trying to click it midair to figure it out. Like I still have people I work with that don't know how to use a computer, so they spend hours at time at that. They're not gonna spend a lot of time to figure this stuff out. It's just, I wrote my orders once, they started my order set when we got the EMR, and I'm never gonna change them again because it's too difficult. But if a patient comes in and says, I'm advocating for this, I think that's important. There's a lot of different ways we can attack pain without just using opiates. But it really requires a lot of kind of work with pre-op, intra-op, post-op, primary care, everyone working together on this in the healthcare system. And pain isn't just about reducing pain, right? The goals are to reduce pain, but also reduce morbidity, reduce some of those adverse effects or misuse issues that occur. Faster recovery, so patients are in better pain control, they can get up and move. If you give someone a whole bunch of opiates and you just had a total knee, they're gonna be sedated, sleepy, tired, and they're not gonna wanna get up, participate with physical therapy, and get out the hospital. And it's the same thing, if the more you're up, the more you're moving, the more you're getting back to normal, the faster you're gonna be able to get home. Improved quality of life, right? Nobody wants to be an addict. Most patients don't wanna be addicted to opiates, so if we can avoid them getting to that place in the first place, they'll have a better quality of life. So here's what we have. So for years, you get pushback, was like, we don't have other medications. I'm not just gonna give my patient Tylenol. True, but we have a lot of other medications out there. We have alpha agonists, we have ketamine, we have NMDAs, magnesium is a great pain reliever, local anesthetics, and a lot of my research is in trying to find ways to attack pain from a non-opiate way. So trying to use longer acting local anesthetics, packaging local anesthetics in different packages to release them over time. And I really think like a lot of medicine has been going towards these depot medications where they're just released over 3, 7, 24, 48 days, depending on what the medication is. And we see that patients probably get better relief because it'd be a more consistent release rather than give them this drug 3 times a day and their blood levels are spiking like this. You can give them this depot form, it's released slowly, and it's a consistent release. And I think a lot of our medicine is really gonna go towards that, not just pain. We see it in antibiotics, we see it in a lot of different areas where to keep that level level where patients do a lot better with that. So the biggest thing here, and I kind of have this whole multimodal approach, but I think what's important here is that first thing in bold, setting expectations. Providers having that conversation with patients that you're going to have pain. If you're pain-free, fantastic, I'm super happy for you, that's great. But don't expect to be. You're going to have pain, it's part of the process, we'll try to keep it tolerable, but don't expect me to just give you pain meds until you have a 0 of pain, because you're probably gonna be at that point not breathing, and I'd rather have you in pain and breathing than not in pain and not breathing. And most patients, not all of them, most patients tend to agree with that statement. Certain patients are like, no, I don't care if I'm not breathing, give me all the opiates. I'm like, great, now you're gonna get less. But right, there's a lot of different medications you could give. It starts, then if I am having surgery, my family members are having surgery, I'm giving them acetaminophen and gabapentin the night before surgery. Getting these drugs into the system before surgery. Taking those medications, again, the morning of surgery, and continuing in. Regional anesthesia, this is directed injections towards nerves to minimize pain. That's important as well. And that's a way to really minimize the systemic effects on patients. Now we're doing research intraoperatively, again, regional anesthesia if you need to, surgeon infiltrations, minimal opiates. We're doing research on opiate-free anesthesia. And for years, anesthesias, right, we've always kind of taken the lazy way out and said, it's not my problem with opiates. I don't write prescriptions. That's on the surgeon or that's on the primary care doctors. We don't write scripts, but we give massive doses of opiates in surgery. And when I started our surgery center at the U, we brought in a nurse anesthetist and anesthesiologist, and I said, we're gonna change how we give anesthesia. We're not just gonna give everyone opiates just because. And there were nurse anesthetists that are like, I practiced for 25 years, I've never not given an opiate in a surgery. I'm like, okay, we're gonna change that. And we've gotten it to about 40% of cases now that we can do a multimodal opiate-free anesthetic approach. Do we know that that has an impact on the outcomes afterwards? No, there's not a lot of data on it. But we can research it and see, does this provide, does us not giving massive doses of IV narcotics decrease the risk of them taking pain meds at 30 days? Because it's hypersensitizing things in their body. And that's the things that we're trying to look at and see, does this make a difference or not? And it's not so much, does this make you have less opiates in the first 3 days after surgery? Because that's great, but if you still are on opiates at 30 days, well then if I gave you less in the first 3 days, who cares? But if we could say you're on less medications in the 30 days or the long term, that's the type of interventions that we really want to do with our patients. Right, fentanyl induction, we talk, other things that are important. Postoperative, again, scheduled non-opiates. This is important for our patients. And then other things. So muscle relaxants, right? Sometimes patients are in pain, and I got called to their recovery room just the other day. This patient's in pain, they need more narcotics. I'm like, well, I write for a small amount because I want to go and assess them and make that determination myself. I'm like, what's going on? Where are you in pain? Like, you know, I think they had a breast reduction. Is the bandage too tight? What's going on? They're like, no, my eye really hurts. And they had a corneal abrasion. Great. They wanted me to give a bunch of different IV narcotics because their eye was scratched. That's not going to help the fact that their eye is scratched. So really trying to figure out what's going on with these patients, or muscle spasms for pain, right? Opiates don't help muscle spasms, but other types of medications help. Topical patches. And then the big thing is non-pharmacologic. And this is something that in America, right, we just try to throw meds at everyone. Take more meds, take more meds, take more meds. As opposed to having that conversation ahead of surgery. What would work for you? Would acupuncture in the hospital work for you? Or would pet therapy, which there's good data on having animals in pre-op, decreasing anxiety for surgery and improving patient outcomes and satisfaction. And there's a lot of people, if you brought a dog around, it would make them so much happier and so much less stressed than sitting there nervous, waiting for surgery, all those types of things. Healing touch, ice to the areas, massage, relaxation techniques, meditation, mindfulness treatments, all of those things have decent data that has outcomes in certain patient populations. And a lot of those patient populations are ones because those patients want that, but they don't get offered it. We're US medicine, and all this Eastern medicine stuff is bogus, and everything that we learned in medical school is right, and all that stuff isn't right. But we're wrong in that. And in certain patients, if that's what's going to work for them, let's try it. And yeah, we still have medications to use if it doesn't work. Right? I don't think hypnosis is going to be great for you to have cardiac surgery. But if it helps for you after surgery to have healing touch or have Reiki or have all these types of things, that's what we should try and at least offer those to patients. And it's really hard to get your administrators to fund someone to come in for that because they're like, well, you know, we don't want to look hokey. But that's what, for some patients, that's what makes a big difference. So these are just going to the different drugs. As we talked about, there's a lot of different medications that we can give. Regional anesthesia, again, we could really attack the pain at certain sites of the body, and it really provides a lot of benefit to patients. Okay, I'm getting close. So what you think about is, you know, we have all these different techniques to minimize it. We really need to change the whole paradigm shift of pain. And you can see, I just skipped through like 15 slides of pain medications. So can you imagine if you're not a pain doctor, that you have to learn all those different drugs and learn all those different side effects and learn which patients can get them and which patients can't? Well, you have to work 100 hours a week and see 40 patients in clinic and figure out how to chart in the EMR and do all your other work. And now you got to learn about all these medications. That's a really difficult task. And right, it's very easy for the government to say, this opiate problem is the doctor's fault, and it's the doctor's fault to clean it up. That's not going to happen. They're already overworked and overstressed as it is. We need to work on how do we, start things from the beginning, involving all aspects of care, our pre-op visit with our nurses, anesthesia, surgeons, our post-op visit with our nurses, phone calls, having people kind of work with patients on this, setting expectations, reducing how much meds we give, but also education of patients. But then, if patients are addicted, not just taking away their opiates and then leaving them to the wind, setting up programs to actually help these people, right? The rest of the world is light years ahead of us in that, right? We say, oh, you're a heroin abuser, you're bad, and we can't set anything up to help you. Canada has done this with patients that are heroin or fentanyl users, that they'll have houses for them to go, and when they overdose, they can treat them with Narcan and save their life. And if you have those, they're going to use regardless, so let's set something up and have things in place to help those patients, right? And that's a huge political issue in America because we think differently than a lot of other countries. But if we could save people's lives with this, we need to start thinking about all these other aspects and not just stop giving opiates. And that's what states are just doing. They're setting all these prescription or these like kind of rules about this is how much opiates you can give. But there's nothing in there about, well, how do you help the patients or how do you educate the providers? How do we combat this in a different way? Luckily, the Surgeon General is an anesthesiologist, which is kind of nice for once. And so he gets it and understands a lot of these things. And a lot of his movement as Surgeon General is to not just say, physicians, stop prescribing pills, but let's find a way to reduce this as a society aspect and not just put everything on the doctors. Because if that's our plan, we're going to be in a heap load of trouble. So with that, I'll end the talk.